So my talk is on surgical correction of orthopedic deformities in cerebral palsy. I also happen to be from the same city where Dr. Rajiv practices, so it's a nice re-meet for us as well from a different city in a new country right now. So I don't have any disclosures. So as we all know that cerebral palsy is a non-progressive upper motor neuron disease in which there is injury to the immature brain. But the musculoskeletal pathology is often progressive. Normal signs which we all know is that muscular imbalance is there, they have spasticity, there are contractures of the joints in the upper and the lower limbs. So we had a total of 177 patients and the age distribution varied from 2 to 24 years, almost a little more males than females. The follow-up is from 1 to 16 years, minimum duration of follow-up is 1 year. There were 21 patients who were lost to follow-up. This is our inclusion criteria, and the most common presentations of patients that we saw were that the upper limbs had the pronation of a forearm, wrist flexion deformity. Lower limbs they usually come in with scissoring because of the tight of hip abductors, and equinus deformity of the ankle. Knee flexion deformity is usually due to tight hamstrings. These were the various surgeries which had to be performed in all these cerebral palsy patients. This is a very simple procedure, rectus femoris straight head tenotomy. You can do it for patients who have a mild flexion deformity around 15 degrees. So as soon as you release the tendon, it snaps, and the tendon is just done to see the tightness. This is the pathophysiology of how we need to be very careful in how we are operating, because we are just basically balancing out the muscles, and as they have residual contractures, we must know what to operate and when. So the complications of hamstring disease is recurrent flexion, recurrent deformity. Complications of PL landing is crouch gait and calcaneus deformity. These are a few cases which we've operated.
Okay.
Can you just click on video?
Can you play the video, please? There's no video.
Okay, this is another video. So this is another child. He had bilateral equinocavalvalis deformity. This is a 6-month follow-up. You can see his left foot is almost rotated by 180 degrees, and we did. We operated on it, and just let me know various procedures which have to be done. For the left foot and the right foot, we applied Ilizarov external fixator, which is a fascinating tool for all these complex foot deformities, in which we can do gradual correction. Also had to do some additional soft tissue procedures for such severe deformities. But the beauty of it is that you can correct these deformities very safely. This is another child having equinus deformity in both the feet, and you can see that after surgery, all these deformities they correct very well. Can you play this video, please? So, all patients improved significantly, deformity corrected to near normal. The results were better in patients who were obviously having within the gene of SCS122 group, and not as good in the gene of SCS3 group, because obviously they have more spasticity and they are more disabled. The complications which we had in severe hip flexion contracture of the hip, iliopsoas release along with hamstring release led to an increased hip weakness, causing the patient to be ambulatory with a walker rather than being independently walking. Overlengthening of tender Achilles led to recurvative deformity in 3 patients. Acute correction of severe contracture of deformities can lead to skin breakdown and wound complications, which should be supplemented with Ilizarov, not just soft tissue diseases. The long-term anticipated problems are recurrence of deformity, especially knee flexion deformities, especially if there's a lot of spasticity. Patients may need a revision or redo surgery in such a case and be explained to the patient at the time of doing the index procedure. The conclusion is that soft tissue release are simple surgeries which can improve the deformity, gait and mobility and functionality of the child. Laser off can be used and should be used for complex knee and foot deformities, adhering to the basic principles of laser off application, which is a magical solution for safe deformity correction. Earlier the correction of the deformity, better are the results. So orthopedic surgery should not be a last resort for cerebral palsy patient, but should be brought at an early stage to a trained surgeon who individualizes the treatment plan according to the physiotherapist.